Next is Brian Forbes with lessons from Philadelphia.
He said, I'm Brian Forbes. Thanks, Gil. I was invited to talk about strabismus surgery tips, which is kind of a difficult subject because I think what we do as surgeons we feel comfortable with, and it's hard to change the mind. I have no financial disclosure, but again, I think it's fairly difficult. So what I decided to present mainly was on resident-driven things I've done in the last 20 years when training residents to make it a little safer for the patient and less stressful on the attending as well as the resident themselves. Also, I've gone on medical missions with a number of seasoned pediatric ophthalmologists, and there are some things that I do that I believe are very basic, but they weren't familiar with those techniques, so I thought I'd throw those out and make sure that everyone here was familiar with them as well. And then I was asked actually specifically to talk about child abuse, some retinal hemorrhage patterns that we have been studying in Philadelphia, and it's not really a strabismus thing, but it is a Philadelphia thing, so I'll get going on that, okay? So the first thing I wanted to talk about was the inverted V technique. This is a technique taught to me by Joe Calhoun at Wills Eye, but basically, whenever you're placing your 6-0 vicryl or whatever suture you're placing through the muscle, you do it sort of in an inverted V fashion. And the reason you do that is you can incorporate more of the muscle and make sure you're not just getting muscle capsule. More than anything, if you do the inverted V technique, which I'm seeing there, whenever the resident's cutting off the muscle, they're less inclined to actually cut the suture along the way. And so the effective insertion of that 6-0 vicryl is going to be, the 0.5 millimeter up on the edges, but centrally it's back about 1.5 millimeters, but the effective insertion will be 0.5 millimeter back. Again, making it safer whenever the resident cuts it off, because at the end you're pulling up pretty well with that vicryl suture, and you can cut that, but as you go across, you're less inclined to cut the suture, although they manage to do it sometimes anyhow. So another technique, although this picture isn't all that good, is whenever I'm teaching a resident, I think everyone would initially, while they're sitting and they're cutting, you are pulling away the conjunctiva with a muscle hook. Whenever they do the initial cut, I ask them to start superiorly. So if they start superiorly, then you can put on a locking clamp, and then it obviates the need for the assistant to hold the conjunctiva away, and you can hound over them and make sure they don't cut that 6-0 vicryl. Hangback surgery, I think with the resident is a good thing. I know some people are for and against it, but I think in small angle or small measurements, it's a pretty successful thing, as supported by the literature. Different people have different ideas on how far and how comfortable they are recessing a muscle by hangback techniques, but regardless, in a resident's hand, I think it's a safer surgery to do. Personally, my limitations in the medial are about 6 and the lateral about 7, but I know many other people do bigger numbers. In cases of constant strabismus, like in hypoxic ischemic injury, when you have an XT, if they don't have a binocular drive, I personally shy away from it, but move forward to either putting the muscle where it's supposed to be or doing resections of the medials. But anyway, so just to review, the figure on the right is going to be just your typical surgery, and it looks easy enough to do to put the muscle there, but in resident's hand, first, second year, something like that, it can be kind of challenging for them. So I think, again, a hangback is a reasonable thing, and then the middle picture shows you, the sutures coming out close to each other, pulling up and tying on top of the needle driver, and then the muscles recess back. That said, even with hangback surgeries, a lot of times these kids don't quite get it right. I think the picture on the right will show you the way it's supposed to be, where the sutures are going to come out together, and they go up basically parallel to one another, and then you can clamp above it and get a good measurement. A lot of the residents, though, don't get them to come out so close together like the middle picture. So in that case, actually, you have to do things a little differently, at least I think you do. My excellent diagram there on the left sort of shows that if you just get the calipers and tie off at, say, 8 millimeters on top with a knot, you're going to lose quite a bit of recession whenever you hang it back because of the 2 millimeters there. And by Pythagorean's theorem, you're really going to, the hypotenuse is going to be about 8.3 millimeters. So when you hang it back, you're really going to be hanging back about 6.3 millimeters. there's a way to work around this. We call it the double needle driver technique, where basically you pull up the sutures like I showed in the last picture. You clamp the base of those sutures, as in the central picture here, with the needle driver, and then you do the caliper measurement above that, and then you release the bottom needle driver, and then you have basically the right number in that setting. And again, I think, in my experience, it's been handy to have a hangback surgery method in your pocket because it allows you to have the resident do both eyes. It reduces the amount of time, builds their confidence, and I think it's a good way to help that. Another thing, this is more driven by the medical missions I was on. In a poorly seeing eye, measuring strabismus is very difficult in terms of using a cover-on-cover test. So what I do in these kids, and I think many of you probably do it too, but it surprised me how few attendings on these trips knew this. But anyway, regardless, over the seeing eye, I put the prism, and then I basically eyeball the non-seeing eye to see which measurement fits well and see when it's straight, and then do my resection on the non-seeing eye or the poorly seeing eye based on those numbers. And I think it's a nice tricky way to do it. You go up with 5 prism diopters, 10, 20, whatever makes that left eye look like it's aligned correctly. All right. And again, on missions, a lot of times they would have a kid with an XT who, whenever they broke down, had a hyper of 4 or hypo of 2 or something like that, and they would talk about doing, the vertical surgery. And I think most of you know, but I think that these kids really respond mostly to doing the horizontal surgery, and if you realign them, especially if the hyper or the vertical deviation goes away at near, you can just do surgery for the horizontal surgery. For nystagmus, again, most of you probably know this, but if you have a nystagmus with a strabismus, it's the fixating eye that's driving the strabismus, so you're going to do the Kestenbaum numbers for the fixating eye, and then the other eye's going along for the ride, so you're going to have to modify those numbers in terms of alignment. And it could get even trickier whenever you have a previous surgery, like a BMR. Many of these kids have had BMRs, and you really need to sit down and figure it out. But again, it's the fixating eye that's driving the strabismus, and that's the eye you would do do the Kestenbaum numbers on, and then in the other eye you would do surgery for just the alignment. And another thing that Joe Calhoun used to do and preached it is, young kids who have a head turn, it's best to wait. I think we all know that. But if you can't wait, if the head position is just fairly large and you're concerned about developmental issues, you can do the Anderson procedure, which you don't necessarily want to stage these kids, but I think a lot of us experience that if we do a Kestenbaum in a younger kid, as they get older, they'll start to take on a head turn again later on in life. So with these kids, a lot of times I'll do an Anderson procedure with big numbers, the 60% augmented recession numbers alone, to get rid of most of the head turn and let them development okay. And then eventually you may have to tweak it by doing the resection numbers, but it's a lot easier to do the resection when they're virgin, when they're older kids. So anyway, I think that's a nice trick up your sleeve. So again, I was asked to talk about this. It's not really a strabismus thing, but it's a Philly thing in a sense that Dr. Levin, Dr. Alex Levin, Gil Binnenbaum, myself, and others have a bit of a consortium who's gone. We've had a number of meetings to decide whether there are patterns consistent with hemorrhages in cases of abusive head trauma. And I think that at this point in time, we have a good idea that through OCT and histopathology, that this is a type of pattern you might routinely see in a kid who has moderate degree of hemorrhages. The hemorrhages are almost invariably in a perivascular pattern, and the reason for that, again, is that by OCT and histopathology, it's shown that the vitreous is more adherently attached to those areas, and so the traumatic injury occurs more often than not in those levels. You have relative sparing of the posterior pole and the mid-periphery due to the vitreous being able to pull it off in those areas. So this just shows sort of the varying degrees of hemorrhages. On the right, you see peripapillary and perivascular pattern with sparing of the posterior pool. As you move to the right, you have more severe injury. But again, it's obeying this perivascular pattern with sparing of the mid-periphery and the posterior pool. On the far left, you'll see the macular cyst. This goes along with is consistent with the vitreous being pulled off, producing a cavity and then bleed into that cavity. Again, with tenaciousness or vitreous attached tenaciously along the perivascular arcade. That said, we've run into a number of the following kind of pictures where they don't really obey this pattern. And so you have, this is a moderate degree of hemorrhages, but not in that perivascular pattern and not with posterior pool or mid-periphery preservation. And what we're seeing in these kids, in looking back at them and seeing what's different, is these kids, in general, have been shown to have chronic subdurals as well as acute subdurals. So it's probably secondary to a secondary injury. When you have a chronic subdural, generally the platelet factors and coagulation factors get lowered, and you have an increased risk of bleeding. And we're hypothesizing now at this point, based on a number of patients, that this pattern can happen, and it's generally secondary to a secondary insult. Anyway, so that's that.
Thanks, Brian. Thank you.